The American Brain Tumor Association is pleased to welcome you back to our webinar series. Our webinar topic today is Sex and Intimacy After Brain Tumor Diagnosis. My name is Umbreen Maan, Program Manager here at the ABTA, and I'm delighted to introduce our speaker. Mary Hughes earned both her bachelor's and master's degree from Texas Women's University and is certified in thanatology. She has been a clinical nurse specialist in the psychiatry department at University of Texas MD Anderson Cancer Center since 1990. She is a charter member as well as a fellow of the American Psychosocial Oncology Society and is active in several nursing societies and has held offices in these. She has received several awards from various professional societies and lectures internationally, nationally, and locally about quality of life issues of patients with cancer and has published on these topics. Thank you so much for joining us, Mary. We're honored to have you. You may now begin your presentation.
Okay. Well, thank you so much for inviting me. I'm honored to be here. I spoke at one of these meetings in person probably 20 years ago. So I'm glad to know that you are continuing them despite COVID. So I'm going to take myself off of the video so that you can focus on the slides. Thank you so much. First of all, we will talk about sexuality, what it is, and what it means. It means a lot of things to different people. So we're going to define sexual health as well as sexuality. Sexual health, according to the World Health Organization, it's a state of physical, emotional, mental, and social well-being in relation to sexuality. It's not merely the absence of disease, dysfunction, or infirmity, and it requires a positive and respectful approach to sexuality and sexual relationships, as well as the possibility of having pleasurable and safe sexual experiences, free of coercion, discrimination, and violence. I think this is an excellent definition of sexual health. So we have all these terms, sex and gender and sexual orientation. What does all of that mean? Sex is physiology. That's your genitals that you were born with. And it's your chromosomes, XX or XY. Gender is how you identify. If you were born with male sexual genitals, but you identify as a female, that's your gender. And it's self-described by pronouns. So you notice I put by my name, she, her. So that's my pronouns. Cisgender, you might have heard that term. That's the gender you were born with. Orientation has to do your attraction to another person, whether it's the same gender, the same sex, or different. That's plain and simple. So what is sexuality? As in the definition of sexual health, it's a positive and respectful approach. It has to do with how masculine or feminine a person is, nurtured by hormones. And as you know, sometimes when you're taking treatment for cancer, your hormones are affected. And it has to do with love, not only love of someone else, but love of yourself. And the very first bond that we ever had was with a parent. So that's going to affect how you bond with other people. It's embedded in long-term memory. So people who have early Alzheimer's, they still remember how to have sex. It's not age dependent. You know, a lot of people think, oh my, you're 50 years old, how you're not interested in sex. Little do they know, right? So young people, middle age, old, and elder. And it's matured by experience. So you remember when you were a teenager, just because everything worked, you thought you knew everything about sex, right? But as you matured, had more experience, then that your sexual life became more satisfying. Body image. And I know that that's something that people struggle with that are dealing with brain tumors. They don't like the way their body looks. They may be on steroids. They don't like the way their body's changed because of the steroids. There may be scars on their head. They don't like that. Also, sexuality is how you relate to other people. You may think you relate to everyone equally, but you don't. And very important for you to remember, it can't be bought, sold, or destroyed. It doesn't matter what's done to your body in an effort to get healthy. You're still a sexual person. Has to do with intimacy. Intimacy is how close you feel to a person and has to do with a high level of trust. And of course, sexuality has to do with pleasure. You know, if it wasn't fun, we wouldn't be doing it, right? Has to do with reproduction. If you so wish, how to reproduce and have children. Eroticism, what turns you on. So as a rule, women are turned on by the written word. Men are often turned on by pictures. And sexuality has to do with sexual activity, right? How do we express our sexuality? One is how we dress. And you know, if you go to the mall and you sit and look to see how the young folk are dressing, they think they're being, individual and I don't want to follow any rules, but they're kind of dressing the same way, right? It has to do with values and attitudes. Often you learn this at home, but as teenagers, you know, that's something to rebel against, and you want to have the values of your friends. Physical affection is also a very important way to express sexuality. Has to do with hugging, touching, and kissing. And think about this. If you're no longer able to sexually perform, that doesn't mean you can't be affectionate with your partner, because who else can hug, touch, or kiss that person like you do? Sensual massage can be an expression of sexuality. Also, a lot of people act out scenarios or fantasies. And you know, that is fine. As long as both of you are willing and accept this, you can do anything you want to together. Sex toys, there's a lot of different sex toys. And as long as you enjoy that and your partner does, go for it. Now, body art, that's tattoos. And what I've found that men who have tattoos, their tattoos often tell a story. Women's tattoos are often more decorative. And I always ask, when I see somebody with tattoos, ask them, a patient, I'll ask them, well, tell me about your tattoo. Also, and 20 years ago, this wasn't an issue. Everybody had pubic hair and nobody did anything with it. Well, now people are shaving it or, designing it, shaving little hearts or whatever. So that's another expression of sexuality, right? Masturbation, which is self-touch, that's also an expression of sexuality. And masturbation can be like exercise. You know, when you can't get out and run and work, you work out to exercise those muscles. Well, masturbation is a way to exercise the penis or the vagina so that it gets good blood flow and it doesn't forget what it's supposed to do. Sexual intercourse can be a way. Oral genital stimulation, another expression of sexuality, anal stimulation, and this can be alone or with another person. So there's a lot of different ways to express sexuality. So Sandra Ludlam said, it makes no difference how old a person is, what their sexual orientation, marital status, or life circumstances are. You should be able to ask and discuss sexual matters with healthcare professionals. Now, I don't know what your experience has been, but after being at MD Anderson for over 30 years, I found that not a lot of oncologists want to talk about sex because what their focus is on getting rid of the cancer, curing the cancer, keeping it under control. So it's important when you bring it up to ask the doctor or the nurse, is there somebody I can talk to about this? So what types of sex are there? And you're thinking, oh, sex is sex. No, no, no. Sex can be relational. That's how you relate to another person. It can be recreational, kind of a fun thing. It can be for reproduction, or it can be functional. Often when people have sex, it improves their mood. It can relax muscles. It can help you relax, period. For some people, after they have sex, it makes them sleepy. Other people get energized. And often after people have sex, they feel comforted and consoled. And very important, it increases pain threshold. So when you're having pain, instead of thinking, oh no, I'm having too much pain to do this, If you can take your pain medicine and then engage in sexual activity, you may find that your pain level goes down. So with women, there's more of a cycle of emotional response in their sexual cycle. First, they have to feel intimate, emotionally intimate. And then think about incentives. Well, if I have sex with this person, what will happen? And then they feel receptive. They feel sexually stimulated and then get aroused. Oh, we can have sex. Then they have desire. Once they're aroused and with sexual activity, have orgasm. Resolution is when the sexual organs return to their normal, non-excited stage. And in men, when they're young, it may take a minute for them to have another erection. But as they get older or with different health conditions, it may take longer. It may take up to a day to be able to have another erection. And so once this happens, there's emotional intimacy. So you can see this is a cycle. So that's why when I see women that have low sexual desire, I ask, so even though you don't have desire, when you hug and kiss and touch and get physically close, then do you get aroused and you have desire and think, oh, we could have sex? Often that's the case, and you can see why. Now with men have more of a linear phase of sexual response. They desire, as you know, testosterone is what mediates sexual desire. Testosterone in women and testosterone in men. However, men have a higher testosterone level. So a study showed that men think about sex at least 11 times a day and women 4 times a day. So there's a disconnect right there, right? So then with desire comes arousal. With the man, the penis becomes erect. With women, the vagina becomes lubricated. Then orgasm, which is the height of sexual pleasure. When the penis emits semen, with the women, there's vaginal contractions. And then resolution. We talked about resolution earlier. So here's this couple. Whatever happened to our sexual relations? I don't know. I don't think we even got a Christmas card from them this year. So it's been a while, right, for this couple. So you hear about sexual problems, sexual issues. So there can be sexual concerns. And this is when you're concerned about changes. You're concerned because it takes longer to have an erection. It may take longer to have an orgasm. So that's a concern. When it's a problem, then there's physiological. That means there's changes in the body that affect sexual functioning, such as you're not able to have an erection, or you're not able to have an orgasm. Altered experiences. It's very, very hard for everybody to have a brain tumor. When you have a brain tumor, your life changes, regardless of how small the tumor is or how big it is. Your life changes temporarily. And so that changes your experience. Often you're not able to work, you're not able to drive, so that changes all those experiences. And you may believe that, oh dear, I have a brain tumor, so we can't have sex. Nobody told you that, right? Nobody told you you couldn't have sex. That's just what you think. Then you've got your partner's expectations. They're afraid, oh no, if we have sex, this won't be good for them. So people don't talk about this, right? This is just what they believe. Altered circumstances. Maybe you're not able to work and you have to move in with somebody else, or you're worried about the light bill being paid or the rent being paid. That's going to take up your thoughts more than having sex and what your past experiences were when you were sick. So sexual dysfunction, this is the height. It's when any aspect of the sexual response cycle doesn't work. Either you're not interested, you're not able to have an erection or vaginal lubrication, or you're not able to have an orgasm. These psychosocial and interpersonal stressors can certainly cause this. Medical illness, as you know, can cause it. And being depressed, that can certainly change your sexual functioning. And different medications can alter your sexual functioning. So you may have diminished, absent feelings about sexual intercourse or desire. or you don't have fantasies like you used to. Often when I see a man, especially with low desire, I'll ask him, is he still having sexual thoughts or fantasies? And often he's not, because the testosterone is low. There may be a lack of responsive desire. When you used to get aroused, now you don't. Anorgasmia, that means no orgasm. And then a sexual disorder, for instance, vaginismus is when the vagina closes anytime anything's inserted in it, and that causes a lot of pain. Dyspareunia, that means pain with sex. That's another sexual disorder. And you see this, you're seeing the impairments in physiology. 190 plus 75, that's not 100. That's because most of the people that I see with brain tumors or with other types of cancer, physically, their body has changed because of the treatment, because of the cancer, because of side effects of the treatment, and they don't physically function like they used to. Some of it can be psychological. You know, when you're not able to have an orgasm, then at some point you think, well, what's the use of even trying to have sex, because I'm not going to get to enjoy it. So with cancer or its treatment, both men and women lose interest. They have diminished orgasms. And one of the things with a brain tumor, you might not remember when you last had sex. There are fertility issues. And often you remember when you have sex, there were nonverbal cues that you'd look at your partner and you knew you were going to have sex. Well, sometimes when you have a brain tumor, you don't recognize the nonverbal cues anymore. Also, as we talked, depression can affect as well as anxiety. Now, women will lose vaginal lubrication and elasticity. Men, their ejaculation will change, and they have ED, erectile dysfunction. So think about this: the more treatment modalities you have, the more side effects. So if you just have surgery, you might not have as many side effects as someone who has surgery, radiation, and chemotherapy. But what happens when your treatment ends? That's when you start thinking about quality of life issues. You remember when you're first diagnosed with a brain tumor, all you're thinking about is living, right? Oh gosh, I hope there's treatment that will help me live. Well, once you have the treatment and it's successful and you know you're going to live, then you think about, well, now I'm alive. How is the quality of my life going to be? And as you know, sexuality is a quality of life. That helps improve your life. So what are other things that can happen to affect a sexuality? One is urinary incontinence, bowel dysfunction. Either you have diarrhea or you have constipation. That's going to certainly affect you, as well as fatigue. And I know from talking to patients all these many years, fatigue is one of the longest lasting side effects of treatment and cancer. Think about it. You have to have some energy to be able to have sex, right? And if you don't have any energy, oh my goodness, thinking about sex makes you tired. Birth control, if you don't want to have children, you have to think what kind of birth control to use. Pain, if you're having pain, you're not thinking about sex. You want to have no pain. Muscle loss, and you find like when you're taking steroids, you lose muscle loss and you don't have stamina. You don't like the way your body looks. You may have relationship difficulties. You know, if you didn't have a good relationship when you started with cancer and its treatment, it probably won't get better. It will get worse. But it changes. Maybe you're used to taking care of your partner, and now your partner has to take care of you. And I know that's very hard for people. So what do men complain about? One is erections, desire, penile length, and the same, the penis is as long. The orgasms aren't as satisfying, and they aren't as powerful, and ejaculation might not be as powerful. So what causes painful sex in men? There may be strictures inside the penis, poor erections. So if your erection is not very firm, it's going to be hard to use it, right? Dry orgasms can cause pain. Curvature of the penis is called peyronie's, and that can cause pain when you're trying to be sexually active. So what are men concerned about? Their sexual self-esteem is not as powerful as it used to be. They don't feel competent sexually. They're not happy with the frequency of intercourse. Once again, they don't like the way their body looks. And they don't feel as masculine as they used to. And one of the fears they have is they will be abandoned by their partner. Women complain about menopausal symptoms, having no desire, having a change in orgasm. It takes a lot longer to have an orgasm, or genital numbness or change sensation. There's certain types of chemotherapy that people get that can cause numbness of the clitoris and cause numbness in the penis, the end of the penis, the glands. And so sex is not going to be enjoyable. Fertility concerns, and once again, painful sex. So when women have menopause, there's any women, not necessarily just with cancer. The clitoris is not as sensitive. They may suddenly have migraine headaches. And you know, with brain tumors, headache might have been a symptom of your brain tumor. But women who've never had migraine headaches before can get them when the estrogen level has dropped and they have headaches. Insomnia, not able to sleep, vaginal atrophy and dryness. The vagina, a healthy vagina that has estrogen, has ridges in it. Without the ridges, it gets very smooth. There may be mood swings. The clitoris and the labia minora atrophy. That means they get very, very small. There may be hot flashes. So because there's low estrogen, there's not a lot of good blood flow to the vagina and not a lot of sensory input that can drive arousal to orgasm. So, a person, you may feel depressed, fatigue, appetite changes, not as alert as you used to be, sleep disturbances, delirium, you get confused. This can be from your medical condition. This can be side effects of your treatment, or it can be psychological response. So if you feel this way, especially if you're feeling depressed and down and not enjoying anything, ask your doctor about getting a referral to psychiatry, because you may have depression and it's a treatable condition. So here you are with desire, and think about the last time you felt turned on or wanted to be intimate, had a sexual thought, got pleasure from any activity, or even had sexual activity. And as I said earlier, testosterone is what mediates that. If you have chronic fatigue, you're not going to be interested. Maybe you have relationship issues that got worse with your illness. Remember, I talked about dyspareunia, which is painful sex, and different kinds of medication can control your desire. So what can you do about it? So in the United States, testosterone is off-label for women, but some doctors will give it to women in hopes to help their desire. Make sure that you get your anxiety or depression treated. Talk about what you like and don't like about your body. Manage symptoms if you're having pain, if you're having hot flashes. If you can't sleep, make sure that you get that taken care of. Erotica, remember I talked about erotica? That's what turns somebody on. Look at the medications you have. Maybe there's some medications that you don't need now. Sometimes what people have to do, because especially when they can't remember when they had sex or not, and if they have low desire, is schedule sexual activity. And I know you're thinking, oh no, that's so artificial, but that sometimes works for people. And they call it date night. So they talk with each other and decide, okay, we're going to have date night every Saturday morning because we don't have to get up and be any place. And so that's a great time to have it, because if a male needs to take Viagra or something like that, needs to be taken on an empty stomach so he can take it in the morning, and then he and his partner can fool around and then have sex, and then afterwards they can go for brunch or something. There's a study and several studies done on kisspeptin. This increases desire in women and in men, but it's still in the study phase, but it gives us hope, right? So the next is arousal, remember? Do you feel sexually excited? Do you feel like you can have an erection, maintain an erection, experience vaginal swelling and lubrication? Feel like maybe you could have an orgasm. Well, stress and anxiety, that's going to affect your being aroused, right? Vaginismus, we talked about painful sex. Vaginal dryness can cause painful sex. Different medications, often we take medicines for nausea or vomiting. We take antihistamines, which can cause vaginal dryness. Menopause, that's going to affect arousal, pain and discomfort, and different side effects of treatment. So what do you do about this? Well, change positions. Maybe there's more other positions that are more comfortable. Renegotiate. Maybe when you're with someone, you don't have to have penile and vaginal intercourse. Maybe there's other things you can do to please each other. Redefine erogenous zones. Maybe the things that felt good and turned you on before your cancer experience, excuse me, are not as sensitive now. So explore to see what's sensitive. Videos, different videos of better sex videos, which are very tastefully done. They can explain all the different kinds of treatment that can help with sexual functioning. Different books. There's a book, they're old, but they're still the same thing. It's called The Joy of Sex, and many of you might have read this. Alex Comfort has died, but the books are still being printed. So they're very, very helpful. Also, MD Anderson has a booklet called Sexuality and Cancer. So if you're interested, you can go to the website at MD Anderson and look under Patient Education, and then download Sexuality and Cancer, because that will help you and your partner read about different treatments and effects that cancer treatment can have on your sexuality. Kegel exercises, that can be helpful. So this is an Aero CTD. It's as big as a computer mouse, has a long tube on it, and this little funnel fits over the clitoris. Then you press a button and it pulls blood up into the clitoris, which makes it more sensitive. However, this costs $350 and insurance won't pay for it. Different lubricants can be helpful. Be sure when you use lubricants to use water-soluble or silicone-based like Astroglide, KY Liquid, Uberlube. Sometimes when, if a woman has severe dyspareunia, which is pain, then they can try the topical lidocaine, liquid lidocaine, to help with the pain. Natural oils like olive oil, almond oil, or coconut oil, they have no petroleum products in them, and they last longer. So if it's going to take a while to complete the sexual encounter, those oils may be better to use because you don't have to stop and add more. Moisturizers, vaginal moisturizers, are like lotion. Like you put lotion on your hands to keep them from being dry. So moisturizers, there's Replens and Refresh. You can buy them over the counter and use them every other night. And that can help with moisture. And then you use lubricants when you're having an encounter. Vibrators can also be very helpful because this can have help to stimulate the clitoris and the vagina to give good blood flow there. Dilators, this is a set of dilators. So sometimes women cannot tolerate anything being in the vagina. So the doctor can order, you can order these online, Soul, S-O-U-L, Source, soulsource.com, and each color, as you see, is a different size. So the woman would use them with lubricants several times a day until, if she has a male partner, she got up to the size her male partner is, and she felt comfortable with that, then she could accommodate her male partner. L-arginine is an amino acid that does not stimulate estrogen, because a lot of people don't want to take estrogen, and it can help increase sexual response. No studies have been done. It's anecdotally. Women have said they notice it helps. So you buy it at GNC, take it for a month. I think it's one a day. If it helps, yay. If it doesn't help, well, then it doesn't work for you. There's vaginal laser treatments, which you would get several treatments, and then it would help improve sexual functioning. But then you have to have another one in 6 months. It increases satisfaction with sexual life, and it takes the place of estrogen products. So Sensate focus exercise that I was talking about, Masterson and Johnson came out with those. This gives you a framework. So it's not sex as usual. You talk to each other about doing this and take time to explore your own sensations. It takes all the focus off of erections, orgasms, and intercourse, but it uses all of the senses. So some people light candles and use the aromatherapy. They give each other back rubs. That's touch. Play music that they like. And it focuses on the receiver's pleasure. So the person receiving this would say, you know, rub my feet or rub my hands or fingers. And then and you would explore what feels good now. What part of the body feels good? And then it would be the other person's turn to say what they would like. Then this takes all the pressure off of having erections. Then when you decide to engage in sexual activity, you know what feels good for that other person and yourself. So these are safe websites. If you don't want to go to the sex store on the freeway and buy vibrators or whatever, these are very safe websites. They may be offensive because they're very explicit, but they will not spam you to any porn. And they have different kinds of lubricants there. Or you can go to drugstore.com, which also has lubricants. So PDE5 inhibitors, that's like Viagra, Levitra, Cialis, Sendra. They have to be prescribed. And a man has to take them about 15 minutes before he wants to have sex, because it can take that long for them to work. Has to be some type of sexual stimulation to help them work. And when he takes that, later on, like that night, he may be able to have a spontaneous erection. So you see the side effects. For most, it's headache, flushing, a dyspepsia, and nasal congestion. All of them have blue vision. Sendra doesn't have blue vision. Now, Cialis, one of the side effects it has that the other ones don't have is limb pain and muscle ache. So I've seen several men that took Cialis, but they can't keep taking it because it makes their muscles hurt. So they'll try another kind. And those are all prescription items, and they need to be taken on an empty stomach. I don't think the doctor that prescribes them often tells the men take it on an empty stomach. Even an hour after you eat, it might not work as well because there's still food in your stomach. So if you take them on an empty stomach, they're much more effective. You're going to have to take one a day. So the vacuum constriction device, this is a very effective way to have erections, but usually you have to shave right around here because this is an elastic band. And once this is pumped up and the penis gets erect, you pull this band down to hold the penis erect. Well, if it's not shaved, it's going to hurt when you take it off. So there's manual or there's a battery. The penis feels cool and it has a hinge effect. So because the erection is not going into here, it stops here. So the penis can be straight, but it's kind of floppy. And it takes time. You can't be spontaneous with this. But it's very safe to use after pelvic surgery, after radiation, after chemotherapy. A lot of men really like it, and insurance will pay for it. Penile injections, they can cause a little burning, curvature or priapism, the cost. The advantage is it works very well. Men with Diabetes, often notice they have erectile dysfunction, and this can help. But I know it's the last thing that any man wants to do is think about sticking a needle in his penis. It goes in the shaft of the penis, but it does work well. The first, it's a prescription item. The first dose needs to be used in the doctor's office, because if it drops your blood pressure and you pass out, well, what good is having an erection if you can't use it, right? So that way they know what the dose is. Now, young men that I know, like in their 40s, 50s, or even 60s, they will think about getting a prosthesis or an implant. So there's no prep, doesn't have any systemic side effect. You have to have surgery, but it's day surgery. You get it done and then you go home. All of these implants are coated with antibiotics, so that decreases infection, but it changes the shape and size of the penis. So these are self-contained, and what the person does is squeeze the tip of the penis and it makes an erection. And then when he finishes, he squeezes it again and it goes down. With the two-piece, the bulb is in the scrotum, and so this is squeezed and the fluid goes up here and it makes an erection. When it's finished, you squeeze again, it goes down. Most of the ones that they use now, there's a bulb in the abdomen, and you press that bulb, which makes an erection. Once you finish, you press it again and the erections go down. So men that I've seen that have had this done have been very, very happy with the results. So here we are now to orgasm. Can you have an orgasm with or without the partner, with or without erection? Changed ejaculation, intensity of the orgasm, or the time it takes to have it. So remember I talked about the numbness on the clitoris or the glands. There can be numbness. And there's two sets of nerves. One set of nerves that everybody has controls erections. Another set controls orgasm. So even though a man may not be able to have an erection, he can still have an orgasm with enough stimulation. There could be dry orgasms, which is you have that sense of relief, but nothing comes out. Retrograde ejaculations are when the orgasm goes into the bladder, and the next time the man urinates, it comes out in the urine. Now, SSRIs, you might have heard of these, like Zoloft, Prozac, Celexa, Lexapro. This is a type of antidepressant, also helps with anxiety. But they work very well, but one of the side effects can be delayed orgasm. If that's the case and you happen to be taking one of these, you may ask the doctor if they would prescribe a different kind of antidepressant. For instance, Wellbutrin or bupropion has no sexual side effects at all. And another thing that can keep you from having a climax are stress, physical and psychological distress. So vibrators can be helpful. Masturbation, because it helps to reconnect to the vaginal tissues, the gland. It includes blood flow. So make sure your physical symptoms are being treated. If you have headaches, if you have pain anywhere, nausea, anything like that. In the physical therapy department, you can get pelvic floor physiotherapy, and these are specially trained physical therapists. That's all they do is help with sexual dysfunction. Once again, use different positions. If you're not in a monogamous relationship, very, very important to use a barrier method so you don't get diseases. Just because you have a brain tumor, you're not protected from any sexually transmitted diseases. We talk about planning for sex and slow down. Remember, part of the whole sexual experience is being able to enjoy everything, not just the orgasm. And I talked about changing antidepressants. So what is a promiscuous person? It's usually somebody who's getting more sex than you are, right? So why don't patients ask us about sex? They're afraid, they're anxious, depressed, maybe they feel guilty because, oh dear, I have a brain tumor and I'm thinking about sex. They may be frustrated, maybe misinformation about they're not supposed to have sex. So the body changes, the role change. And I think that everybody that has cancer, doesn't matter what kind of cancer they have, they're grieving. They're grieving for the loss of their healthy self. And so that's a process. And, you know, they have performance anxiety. And so how can they ask about this? Sometimes religion gets in the way. Maybe they're concerned that they'll have a seizure if they have sex. It has to do with money. Maybe they're not married. And at some point they were going to get married and now they don't feel like they can. And so maybe they're embarrassed about that, or their sexual orientation is different. So why don't we ask about it as providers? Well, we don't have a lot of education about it. Maybe we think it'll take a lot of time. Diversity, maybe there's people we're seeing young enough to be our grandchildren or old enough to be our parents. And we don't know how exactly to communicate that. And then we think, oh, no, now we have to ask about sex. So it's a strain on the role and the change. Maybe we have performance anxiety. We're not comfortable using the terms, you know, clitoris, penis, vagina, those things. Mostly, we don't think it's very important to you or your partner. That's why we don't ask about it. And there's not really a standard questionnaire on sexual function. Usually, the focus is on penile vaginal penetration, but there's a lot of people that have sexual activity that doesn't involve penile vaginal penetration. So maybe we're afraid of embarrassing the patient. You know, if somebody asks, I'm sure people haven't asked you this very much, sexually, how are things going? That's an easy question, right? 4 words, and all you have to do, and what I've noticed is people will shake their head and go, it's not. Maybe we don't know what else is going on besides the cancer. What else do you have? Diabetes, other things like that. And we think cancer is a higher priority than sex. Well, when you're living this, and this is a quality of life issue, it becomes a priority. We assume maybe that you're not going to get paid if you ask about sex. And with women, there's not a lot of sexual treatments. And many don't know about the treatment options. So what can you do? Experiment. You know, mostly if somebody is in a committed relationship, they have sex maybe 2 or 3 different ways. Well, experiment with doing it different ways. You know, I read about this, or I saw this picture, let's try this. And encourage touching. Touching for touching's sake. Not necessarily touching as foreplay, but touching because it feels good and it's soothing to each person. Communicate, talk about this. What I found is when people can't perform sexually, their partner thinks they don't want to have sex with them. That if they had a different partner, they would have sex. And that's not true at all, as you know. That's the great thing about that booklet, Sexuality and Cancer, because it explains to the partner, it's not about you. The person with cancer don't want to have sex with anybody, not just you. Safer sex, like I said. And you know, if you need some endurance, and you do have to have a little endurance, right, and stamina to have sex, maybe get OT or PT order for that. Pelvic floor therapists can be helpful. Plan for sex still. Support groups can be helpful because as a rule, people don't talk about sex. So when you're in a support group, you find out, I'm not the only one that's not interested in sex. Other people are too. So some frequently asked questions. Can I give my partner cancer? No, you can't. You have a brain tumor. Will having sex make me have a seizure? As a rule, it won't. For some people, when they have an orgasm, it can. But you would know this, and you would adjust your anti-seizure medication. Is there something I can take to give me enough energy to have sex? Well, that's a good question. For some people that have fatigue, ongoing fatigue all the time, MD Anderson has a fatigue clinic, and maybe other institutions do too, but there's a drug called modafinil or even Ritalin that can help give a person energy. But this is something the doctor would prescribe and the dose and tell you how to take it. And some people only need to take it in the morning. Others take it in the morning and at noon. There's people I see that can't even get dressed unless they take this because they've had cancer 20 years ago, but they still have that ongoing fatigue. So this is and I touched on this, I don't want to have sex, but I'm afraid my partner will leave me if I don't. And that is a big fear that I see with people that aren't interested in sex. So it's important to talk to your partner about this. Sex is kind of like the cherry on the top of the sundae, right? If you don't have the cherry, you still have the sundae. You still have the relationship and the history with your partner that nobody else has, and all the memories that you share with that person. And talk to the person. Get that booklet. Maybe you could see a marital therapist if this is a big issue. Now, some people don't use vibrators and want to know, well, how can I ask my partner about using a vibrator when we have sex? Well, I would think be open about it. You know, you could say, well, you know, I read about using vibrators, or some people I've talked to use them and find it's very, very helpful for men and women. And then ask, so what do you think about using a vibrator? You think that's something maybe we could try? So thank you so much for this, for letting me speak to you. And are there any questions?
Thank you so much, Mary, for that presentation. As Mary shared, we do have some time for questions now. If you have a question that you'd like to ask, please type and submit it using the Q&A button on the bottom of your screen, and we'll answer questions as time allows. All right, so one of the first questions we have here, Mary, you had talked about some of the different treatments that can impact sexual functioning, like chemotherapy, radiation, and other treatments. Can you touch on steroids for a moment? Can steroids impact sexual functioning?
Steroids can, in the way that they affect how you look. Long-term use of steroids, you know, you get the round face, the belly. And even though steroids can give you energy, long-term use of steroids can also affect bones, density, those different things. So that's what I know about steroids.
Thank you so much for sharing that. Can you also, you know, when we think about body image, a big piece of it can also be hair loss. We know that chemotherapy can cause hair loss when brain tumor patients are going through surgery. They may have some patching and shaving. Can you talk about or provide any advice or insight on patients on how to cope with hair loss? This question is coming from someone who's unfortunately experienced permanent hair loss after their treatments. So particularly thinking about loss in that permanent sense.
Well, and that's another fear that I hear from people getting radiation or even surgery, that their hair will come out and then it won't come back. And that is very difficult. Often what people do is wear scarves or hats. Unfortunately, almost everybody wears baseball hats, right? And so, and it's not something you usually would wear having sex, but sometimes people incorporate that in how they look. They look at themselves, and even though they have no hair, they have scars on their head, that's a healthy head you're looking at. That before, when you had hair and had no scars, you had a brain tumor that was not being treated. Now the brain tumor is gone. It was successfully treated. And you think, is it worth my hair to have my life? So you can kind of put it in perspective.
That's a beautiful way to look at it. Thank you so much. I hope that many of our attendees can benefit from that perspective. Another question we have here is asking about how to talk about some of these issues with your healthcare team. You know, you brought up some of the barriers as a provider that might stop you from talking about this. As a patient, how can patients bring up these conversations with their providers?
Well, I found from talking to patients over the years, But one of the most approachable people to talk to are the nurses. So, you know, before the doctor comes in, often there's a nurse doing things for you, and you know, so how are you doing? Anything different? That's an ideal time to say, you know, sex, we're not having sex like we used to. And so hopefully the nurse is comfortable with, okay, tell me, you know, what's going on. Or she will say, he will say, you know, well, let us refer to somebody. At MD Anderson, I'm the person that gets the referrals for sexual dysfunction. And other institutions, I don't know who it is. Hopefully, I mean, there's some institutions that actually have a sexuality clinic. We don't. But hopefully there'll be somebody that they can refer you to. Or that, you know, hopefully there's a social worker that feels comfortable talking about this. Or, you know, your doctor may actually be interested in talking about it.
Thank you so much for
But
that
it
one.
is hard. It is a hard thing to talk about.
Certainly. And that leads into the next question. So it's hard to talk about in general with your providers. It can also be hard to talk about with your partner and, you know, the person that you're in this romantic relationship with. What advice can you share for either the patient or the loved one on how to talk about sexuality, your concerns, lack of desire, if that exists?
Well, and I can't say this enough, but if you download that booklet, Sexuality and Cancer, it's free to anybody. It's very good because it's almost like a workbook. It's not just pages, but so it's for you and your partner to read together, and for the partner to say, oh, well, I didn't know this would affect you sexually, or I didn't know that this would happen. And it may even shed some light on you and why you're not interested in sex. So something to read, because that's a safety thing. So you're reading objective information, and then you can personalize it by saying, oh yeah, that happened to me. And even like the Alex Comfort book, it's very good. It's excellent. And unfortunately, we spend more time deciding about buying a car than we do about sex, right? It's kind of magic. It just magically happens. And nobody has to work at it or anything. So it's very important. And it's hard, you know, if there's something you miss, maybe you're not touching each other like you used to. You're not hugging. So you could go and hug your partner and say, I really miss the hugs. And interesting for you to clarify that you miss the hugs for the hugs, not necessarily as a precursor to having sex.
That's so important. Thank you so much. Also kind of continuing on with that conversation about relationships, I think this is also a very important one for someone who may be dating or entering new relationships. It can be difficult to determine when is the right time to talk about, I have a brain tumor, or I'm going through treatment, or, you know, I may have all these concerns related to my sexual functioning. You know, when do you talk about that? When do you bring that up? Or what insight can you share for those people who are entering a new relationship while going through a brain tumor diagnosis?
That's a great question, because people who are single and not in a relationship, that's one of the biggest fears they have. When do I tell the person I'm dating that I have cancer? Or do I tell the person I'm dating I have cancer? Because it's an intimate thing to tell somebody. I've been diagnosed with cancer, or I've been treated for cancer. It's very intimate to tell somebody. So you don't want to tell them right away, because you might not like the person anyway. After you've had a date or two, you may decide, nah, not for me. So it's very much a personal decision when to tell the person, and how to tell them, and how much to tell them. You know, some people will just say, well, I've been treated for cancer, period. And see what response you get from the person. And then some people tell me, you know, I'm glad I mentioned this to the person I was dating, because they didn't ever come back. So it's better to know then than to think you're going to have a relationship with somebody supporting you when you really need it. They left. So it's a hard decision, but when it feels comfortable for you to tell the person.
Thank you so much for that insight. Another question we have here is asking about tumor location. Do you know if where in the brain the tumor is located, if that impacts what types of effects you may have on your sexual functioning or your sexual desire? Does that make a difference or an impact?
Well, certain places where the tumor is can affect your person. I'm sure some of you are aware of this. So it can affect your personality. Maybe you were an easygoing person, and now one of the symptoms of your brain tumor, either you're grouchy and you're hard to get along with. Well, that's because of where the brain tumor was. Also, if the brain tumor is in certain places, you may fall, and it may affect your walking, it may affect your ability to touch and to hold, those kinds of things. So it can affect it that way.
And a follow-up question to that, do you know then in those cases where the impact was due to the location of your tumor, do you find that these concerns, these side effects reduce over time as treatment continues, as the tumor shrinks or may be removed after surgery?
Yeah, it does. The answer is, as the tumor responds to treatment, then those effects go away.
All right. Well, it does look like, unfortunately, that is all the time that we have for questions. Thank you all so much for your wonderful questions. So many good ones. And Mary, thank you so much for taking the time to share your insight and your expertise. I hope that our attendees have learned a lot. I certainly have gained many wonderful takeaways myself.
Thank you. It's been my pleasure.
Great. Well, as I had mentioned at the beginning of this webinar, we would love to encourage you all to share your feedback with us. You can do so either by scanning the QR code on the screen on your mobile device or following the link on the screen. Please do share your feedback with us. It's very important as we plan for future programs. And again, I just want to thank you all for joining us, and thank you to Mary for your time. If you're looking for more content like this, please check out our next webinar, Understanding Clinical Trials and Improving Access, presented by Dr. Chow Pei Weathers on May 24th. For more information about ABTA's programs, events, and services, visit ABTA's website at abta.org, email us at info@abta.org, or call the ABTA Care Line at 1-800-886-2282.